Zollinger-Ellison syndrome is an gastrointestinal disease. Look at this picture, shows that tumor in pancreas, peptic ulcer. Look at this. Then CT scan findings and MRI findings. Look at this detail going on. Introduction. Zollinger-Ellison syndrome is a rare disorder characterized by the formation of gastrin secreting tumors called gastrinomas, primarily in the pancreas and duodenum. These tumors cause excessive production of gastric acid, leading to recurrent and severe peptic ulcers and gastrointestinal complications. ZES may occur sporadically or as part of genetic conditions such as multiple endocrine neoplasia type 1. Definition. Zollinger-Ellison syndrome is defined as a gastric acid hypersecretory condition caused by gastrin secreting neuroendocrine tumors, typically found in the pancreas or duodenum, leading to recurrent peptic ulcer disease and diarrhea. Etymology. The term Zollinger's Ellison syndrome is named after American surgeons Dr. Robert Zollinger and Dr. Edwin Ellison, who first described the condition in 1955. It reflects the syndrome's hallmark discovery of gastrin secreting tumors causing severe peptic ulcers. Epidemiology. Zollinger-Ellison syndrome is rare with an estimated incidence of 0.5 to 2 cases per million. People per year. It typically present in adults between the age of 30 and 50, and about 20 to 25% of cases are associated with multiple endocrine neoplasia type 1. Types. 1. Sporadic ZES. 80% acquire without a family history. 2. Familial ZES associated with MEN1. 20% occurs as part of MEN1. Syndrome, which involves multiple endocrine gland tumors, example parathyroid, pituitary. Causes: 1. Primary cause gastrin secreting tumors, gastrinomas. 2. Other contributing factors: MEN1 gene mutation, unknown etiology in sporadic cases. Risk factors: 1. Genetic predisposition, especially MEN1. 2. Family history of endocrine tumors. 3. Male gender, slightly more common. 4. Age between 30 to 50 years. 5. Personal history of peptic ulcers. Unresponsive to treatment. Complications: 1. Recurrent peptic ulcers. 2. Gastrointestinal bleeding. 3. Perforation of ulcers. 4. Esophagitis. 5. Diarrhea and malabsorption. 6. Weight loss. 7. Metastasis of gastrinomas, often to the liver. Pathophysiology. Here is the step-by-step pathophysiology of ZOLLINGER-ELLISON syndrome. Step-by-step pathophysiology. 1. Development of gastrinoma. A neuroendocrine tumor forms usually in the duodenum, pancreas, or peripancreatic tissues. 2. Excess gastrin secretion. The tumor secretes large amounts of gastrin, a hormone that stimulates acid production in the stomach. 3. Stimulation of parietal cells. Gastrin travels through the bloodstream to the gastric parietal cells in the stomach lining. 4. Increased hydrochloric acid (HCl) secretion. Gastrin activates H plus K plus ATPase pumps in parietal cells, resulting in hypersecretion of gastric acid. 5. Lowering of gastric pH. The excessive acid significantly lowers the pH of the stomach contents. 6. mucosal damage and ulcer formation. The high acid concentration overwhelms the protective mucous lining of the GI tract, leading to recurrent and multiple peptic ulcers, often in the duodenum or jejunum. 7. Inhibition of digestive enzymes and absorption. Low pH inactivities, pancreatic enzymes, and bile salts, leading to malabsorption, steatorrhea, and diarrhea. 8. Possible tumor metastasis. In many cases, especially when not associated with MEN1 gastrinoma, may metastasize most commonly to the liver. This stepwise disruption explains the classical clinical features of ESETS: severe ulcers, abdominal pain, and diarrhea. Signs and symptoms: 1. Recurrent peptic ulcers, especially in atypical locations. 2. Severe abdominal pain. 3. Nausea and vomiting. 4. Gastroesophageal reflux disease. 5. Diarrhea. 6. Weight loss. 7. Fatigue. 8. Bleeding ulcers. Diagnosis: A. Laboratory tests. 1. Fasting serum gastrin level. 2. Secretin stimulation test confirms ESETS. 3. Chromogranin A tumor mark. B. Imaging studies. 1. Endoscopic ultrasound. 2. CT scan MRI. 3. Somatostatin receptor scintigraphy. 4. GA68 dotatate PET scan. Preferred in modern diagnosis. C. Endoscopy revolves multiple or recurrent ulcers in the upper GI tract. Nursing diagnosis: 1. Acute pain related to ulceration of gastrointestinal mucosa. 2. Imbalanced nutrition less than body requirements related to malabsorption. 3. Risk for bleeding related to ulcer complications. 4. Anxiety related to chronic illness and fear of cancer. 5. deficient knowledge related to disease condition and management, medical management. 1. Proton pump inhibitors, omeprazole, pantoprazole to reduce acid secretion. 2. H2 receptor antagonist, ranitidine, less commonly used now. 3. Somatostatin analogues, acitreotide to inhibit gastrin release. 4. Chemotherapy for metastatic gastrinomas. 5. Surgical removal of gastrinomas when localized. 6. Liver directed therapies for liver metastasis. Nursing management. 1. Monitoring for signs of GI bleeding. 2. Assesses for pain level and pattern. Administer prescribed analgesics. 3. Monitor gastric pH and gastric secretions, medications, follow-ups and symptoms of recurrence. 4. Provide nutritional support and small, frequent meals. 5. Educate patient and family about medications, follow-ups and symptoms of recurrence. Treatment options. 1. Medical therapy including high dose PPIs, acitreotide for hormonal control. 2. Surgical therapy, tumor resection, curative if localized, doubling surgery in metastatic cases. 3. Endoscopic procedures. 4. Chemotherapy. 5. Liver directed therapies for hepatic metastasis. Psychosocial medicine. 1. Emotional support and counseling to cope with chronic or potentially malignant condition. 2. Support groups. Connect with others dealing with SATS or MEN1. 3. Patient education. Understanding the disease, lifestyle modifications and self-care. 4. Stress management techniques such as mindfulness and relaxation therapy. 5. Vocational counseling for those whose symptoms interfere with work. Prevention. 1. Primary prevention is not possible due to its genetic sporadic nature. 2. Early detection in at-risk individuals, example MEN1 families via genetic screening. 3. Routine monitoring of patients with MEN1. 4. Avoid NSAIDs and smoking, which can exacerbate ulcer formation. 5. Prompt treatment of peptic ulcer symptoms to prevent complications. In conclusion, Zollinger-Ellison syndrome is a rare but serious condition caused by gastrin-secreting tumors leading to excessive gastric acid production and severe peptic ulcers. Though challenging with modern diagnosis, pharmacologic therapy, and surgical options, the disease can be effectively managed. Early recognition, appropriate treatment, and psychosocial support are vital to improving patient outcomes and quality of life. Thank you. Have a nice day.